now moving on to how the X-rays, when they reach the patient, interact with matter. So you have the three main ones, the coherent scattering, Compton effect, and photoelectric. The two really, really important ones are Compton and photoelectric, and these two don't really occur at diagnostic imaging level. Only Compton and photoelectric are important for making an X-ray. So, first one, classic or coherent scattering, not one of the more important ones. So this scatters refers to the X-rays that have been randomly reflected from their initial path. It's due to interaction with matter, blah, blah, blah. With classic scattering, most of the photons continue to travel in a forward direction towards the film, this occurs with low energy X-ray photons. So with diagnostic imaging, we deal with higher energies than this. We're up at about 70 kV. So they go through and they change direction. Cool. Neither of them, there's no change in photon energy or wavelength, so it doesn't particularly matter. Blah, blah, blah. Compton effect. As diagnostic X-ray photon of moderate energy may undergo a Compton interaction. This is the main interaction that occurs through most of the range of diagnostic X-ray. So what you get is you'll get an incident X-ray will come in, it will knock off a Compton electron, and then X-ray will scatter in a different direction. So this X-ray will lose some of its energy to knock off an outer shell electron, and then the leftover energy will continue on in a different direction as a lower energy X-ray. Whereas for the photoelectric effect, the incident X-ray comes in and it's completely absorbed by that electron in the inner shell, and the photoelectron gets fired off. So the X-ray doesn't change direction, the X-ray is completely absorbed for this one. So scattered radiation, as the number of scattered X-rays increases, the radiographic loses contrast and appears dull, fault, and blurred. So that's because they're traveling in a different direction to the primary beam. So obviously they're not coming from where you want, and you're going to get this blurry image. So the main factors that influence the scatter radiation, you've got KBP, patient thickness, tissue density, and X-ray beam field size. So if you decrease the KBP, you're going to decrease the scatter because it's decreasing the energy. So those lower energy X-rays are more likely to be absorbed by the patient. So you don't get the scattered radiation, but you now get a huge increase in patient dose. Part thickness, obviously if there's more matter for the X-rays to pass through, you're going to have more chance for one of these interactions to occur. So that just means that if you decrease the part thickness, you decrease the scatter. Obviously patients generally are as big as they are. You can try getting them lying down or compressing them if you can, but again, not easy. And same part density. So the density of the tissue, if you increase the density, you're going to increase the scatter because there's more atoms for the X-rays to interact with. X-ray beam field size, if you increase the X-ray beam field size, all other factors staying the same, you're going to increase the number of X-rays, so you're going to increase the chance of one of those interactions occurring, so you're going to increase the scatter. Decrease the field size, less number of X-rays, less scatter. Focal spot size. So the smaller the focal spot size, the greater the detail. So this comes back to basically the effective and actual focal spot sizes. It's determined by the filament size, so you can either have one or the other. You can't really have a huge range. So we talked about the actual and effective focal spot. So the actual focal spot is where the anode electrons actually strike the anode. The effective or projected focal spot, this is how the actual focal spot looks from the perspective of the patient. So if you were looking at the target, how big a focal spot would you see? So the effective focal spot, this is the one that the patient sees on the target, is the effect, appears smaller than the actual focal spot due to the line focus principle. Depends on the size of the actual focal spot, so which filament you use, and the anode angle as we talked about. The smaller the anode angle, the smaller the effective focal spot. Here we go. This is a large angle. This is the actual focal spot, so where the electrons actually hit the anode, and this is the effective focal spot here. And that's the size that the patient would see. The patient would be standing down here. Then with a smaller angle, you get a smaller effective focal spot. Penumbra. So because the X-rays aren't produced from a single point, they're produced from thousands of different atoms which act as points across this distance. You're going to get a penumbra, which is basically like the edge of a shadow. So if you look at a shadow of your hand in here, you can potentially see 5 or 10 different shadows from all the different lights that are around. Same thing for an X-ray. So you get this one main shadow where none of the X-ray can go through, and then you've got this little edge of shadow where some of the X-rays can't go through the object, go through the object and can't reach here, and some of them go around the object and still reach here. That makes sense. I probably just confused the shadow. This is basically just the blurriness of the image. So again, see here, focal spot blur. So the penumbra is affected by the focal spot size. The smaller the focal spot size, the closer to a single point of production of X-rays, the smaller the penumbra. The object to film distance, the shorter the object to film distance, the decreased penumbra. So if you move the object closer to the film, you get less penumbra. The source to film distance, the longer the source to image distance, source to film distance, source to image distance, same thing. The longer that distance, the smaller the penumbra. And the source to object distance, the longer the source to object distance, the smaller the penumbra. So distortion is obviously just a misrepresentation of the true size and shape of an object. The further you move the object from the film, the worse this is going to be, because the X-rays travel in a divergent line, it's going to magnify everything. So you can get size distortion or magnification, and you can get shape distortion. It depends on a whole lot of things about the object, as well as where you've got the source and the film in the object. So here we have the object is a little bit away from the film, so you get some slight magnification there. When you have unequal distance from the film of the object, you're going to get unequal magnification. So the part that's further away is obviously going to be magnified more than the part that's closer. Same here. And then same thing with changing the film orientation. So a large source to image distance will decrease magnification, a large object to film distance will increase magnification. So same object, short object to film distance, not so much magnification, large object to film distance, more magnification. So when we're looking at a chest X-ray, what we'll do is we'll take it P to A, so the chest will be right up against the film. So if the X-ray tube was over here and the film's over there, you'd have the patient standing like this. That's to reduce the magnification of the heart. When we're taking thoracic spine X-rays, we'll do it A to P because we want to see the spine. So we'll put the spine as close to the film as we can to reduce the magnification of the spine. Moving on to grid. So a grid basically just tries to stop some of that scatter radiation from reaching the film to decrease the blurriness. So what you do is you align the grid so that it's in the same axis as the primary radiation beam. So photons that go through the patient without interacting at all are able to pass through the grid and reach the film unaffected. However, any scatter radiation that rises within the patient is going to come off at a different angle, and hopefully it's going to be absorbed by the lead strips. So the grid doesn't reduce patient radiation dose. If anything, it increases it because now some of these scatter photons aren't reaching the film. So you're going to have to increase the amount of X-rays so you can maintain the same density. Because this happens after the patient, it doesn't reduce the dose. If you put a collimator in front of the patient, obviously it's going to stop X-rays reaching the patient. That's going to decrease dose. this happens after the patient, so there's no way for it to reduce patient risk. So the grid ratio, they range from about 5 to 1 to 16 to 1, and it's the ratio between the height of the lead strips and the distance between the lead strips. So these black lines are the lead strips. The grey is the either plastic or some other material that's radiolucent, in between them, holding them together, and then H is the height. So grid frequency is the number of grid strips or lines per inch. So those with high frequencies show less distinct grid lines on a radiograph, and those with low frequencies. Obviously, more lines, more lead, more expensive to produce. Absorption versus attenuation, so this is quite an important concept. Absorption refers to the transfer of energy from the X-ray beam to matter. So how much energy in the beam is given to matter. It's important with regards to hazardous biological effects. So this is the energy that is going to cause the ionizing effects on your body and it's going to cause the damage. Attenuation, however, slightly different to absorption. It includes absorption, but it also includes the energy that's lost by scatter. So some of those X-rays aren't going to be absorbed by the patient, they're just going to be scattered by the patient. So they'll still leave the patient, therefore don't contribute to the harmful effects, but they are not going to reach the film, so they are still contributing to the attenuation. Does that make sense, the difference between these two? So filtration, this is the selective removal or attenuation of low energy photons from the X-ray beam before interacting with the patient. So remember we talked about increasing the average energy. This is another way of increasing the average energy. So the process of increasing the mean energy of polyenergetic radiation, long words for no reason, by passing it through an absorber. Those low energy X-rays, if they weren't filtered out, would just normally be absorbed by your skin or your subcutaneous tissues. They don't add anything to the film, obviously, because they can't get through the patient, but everything, all their energy is going to be added to the patient dose, so that's bad. And this is what we call hardening the beam. Air gap technique. So obviously what we want to do is get the patient's anatomy as close to the film as possible to reduce magnification. Sometimes this is impossible, especially with like a lateral cervical where you've got the shoulder in the way. So if the patient is moved away from the film, the concentration of scatter radiation making it to the film decreases. So obviously there's a higher distance there, and any scatter radiation that goes off on an angle is going to have more distance to go away from the film, if that makes sense. So less scatter radiation is actually going to reach the film. So scatter radiation decreases not from filtration, but from the scattered photons now missing the film, in this case. We've been talking about air gap. It's not because you've filtered out the scatter radiation, it's actually because the scatter radiation's gone in a completely different direction and missed the film. So if you look here, a normal object right up against the film, any scatter radiation, this scatter radiation here would still hit the film right on the edge, whereas if you move this away, that same scatter radiation is now going to fly right past the film. So you don't actually remove the scatter radiation, it just now misses the film. These are the 5 views that we do that have an air gap technique, again because of the shoulder. So lateral cervical, left and right oblique cervicals, and then cervical flexion and extension. To compensate for this, we'll take it without a bucky, because obviously that scatter radiation now isn't reaching the film, so it's not going to contribute to the density, so we have to either increase the factors or remove the bucky. Again, we don't want to do this, but because patients have shoulders, we have. Intensifying screens convert the energy of the X-ray beam into visible light. So remember, X-rays themselves aren't particularly good at exposing radiographic film. visible light is. So what we'll do is we'll use the intensifying screens to convert the energy of the X-ray beam into that visible light so they can expose the photographic film at a much more efficient rate. So, and even then only about 30% of the X-rays hitting the intensifying screen are going to interact with it. Overall, this is going to decrease your patient dosage because it's, ramping up the efficiency of converting that X-ray energy into a visible image. So this is what that looks like. We've got the base here, which is just made out of like a, can't remember what it's called now, but it's like a solid material just to hold it in place. You've then got a reflective layer. You've got the phosphor, so this is what actually lights up when it interacts with the X-rays, and then you've got the protective coating on top so that you don't damage it with your nails or scratch it in the cassette or anything. Some of the common phosphors used is calcium tungstate, zinc sulfide, and barium lead sulfate. Some of the rare earth phosphors, gadolinium, lanthanum, and yttrium. You don't need to remember the exact names. If you just remember rare earth versus common phosphors, you should be right. Yeah. So the reflective layer, the rare earth screens are so efficient that they don't need the reflective layer because they're much more efficient at absorbing the X-rays in the first place than the common phosphors. So you don't need to reflect the light that's going in the wrong direction back onto the film. So this is what it looks like with and without a reflective layer. With the X-ray coming in, interacting with the phosphor layer, producing light in all directions. With a common phosphor, you need to put this reflective layer in so that the light will bounce back towards the film, which is down here. With a rare earth phosphor, they're so efficient that you just don't need the reflective layer. Polyester, that's the word I was looking for. So the film base, similar to the intensifying screen base. Thank you. It's made out of polyester. The emulsion, so this is what shows the image, is produced. Is made of silver halide crystals, so mostly silver bromide, but a little bit of silver iodide, and it's mixed in with gelatin just to hold it all together. You then put another super coating of gelatin on top so that again you're not going to scratch off the silver halide. So this is what it looks like. Got the big base in the middle. This is a double emulsion film, by the way. Emulsion down here and emulsion up here. The polyester base in the middle. You've then got the adhesive layer just holding the emulsion to the base. You've then got the emulsion, which is a silver halide, as well as some gelatin, and then you've got another super coating of gelatin so that it doesn't get scratched. Parallax unsharpness, so this is due to the double emulsion, so because you've got emulsion here and emulsion here, if the light's travelling through on an angle, you're going to get part of the image over here and part of the image over here, and when you put that up on a viewing box to look at the X-ray, it's going to look a bit unsharp. Obviously these are such tiny measurements that you're not going to notice. Obviously the greater the tube angle, the worse this will be. Moving on to some of the units that we talked about. So the Röntgen is the amount of ionization left behind by radiation. Almost the earliest unit of radiation exposure. And it's been linked with the SI unit of Coulomb per kilogram. We then moved on to the RAD, or the radiation absorbed dose, which is to do with patience and matter. So how much radiation is absorbed by a certain amount of matter, and this is linked to the grade. So the SI unit is the grade. The REM is the rad equivalent man, so this is for occupational exposure. In terms of X-rays, the REM and the rad will be the same, but if you're using other types of radiation like alpha particles or beta particles, then the quality factor is going to change, and that's going to mean that the REM will be either higher or lower than the rad. And then the REM SI unit is the Sibert. So some of the general principles. Any exposure is harmful, obviously, so you have to justify it, so the benefit needs to outweigh the harm. You need to optimize it so that you get the maximum benefit from the minimum amount of radiation. Minimize, obviously need to follow ALARA as low as reasonably achievable. And then you also need to follow the laws in the country to look at the maximum for workers, for the general public, pregnant patients, all that sort of thing. So the yearly maximum for workers is 5 rems for 50 millisieverts. To reduce the exposure to the patients, you should use a high KVP and a low EMAS. Use the smallest field size possible while still getting all the relevant anatomy. Use the proper filtration, so get rid of all that low energy X-rays, all those low energy X-rays. Try to avoid repeats, so you need to know what you're doing and you need to do it properly. You don't want a greater than 4 to 6% repeat rate. And again, when you can, use gonadal shielding. Moving on to some of the protective barriers. We've got 2 types of protective barriers, primary and secondary. So the primary barrier is any barrier where the primary beam can be directed towards. It has to be equivalent to a lead sheet of 2 millimeters. So this is the equivalent of basically 4 inches of masonry, really. A secondary barrier, basically any other wall within the X-ray room. It needs to be the equivalent of 1 millimeter of lead. So 4 thicknesses of 5.8 inches of gypsum board is adequate. So the door, the wall behind the X-ray machine, and the control booth are all secondary barriers. Moving on to some of the digital X-rays. So this is computed radiography. So this is the one where you have to take the receptor out of it and then put it into a laser reader, and it reads it and then erases it. This is called indirect digital radiography. So you still have to do 2 steps to get the image. So the X-rays will stimulate the phosphor. You then fire a laser into that, and the phosphor that is being interacted with by X-rays is going to fire light back. You then read that light, and it'll give you the image. You then have to use intense light to completely erase the receptor. Digital radiography, much better. No in-between step now. It'll directly transform the energy X-ray into digital information and send it straight to the computer. So you don't have to do that intermediate step of scanning. You don't need phosphor plates, but it is a lot more expensive than the other one. But once it's fit, there's much less ongoing costs. You don't have film, darkroom, all that sort of thing. And you have to refit a lot of it if you don't already have a digital suite installed. Both have better contrast than plain film X-ray. But the spatial resolution is much worse. So because a pixel can only be a certain size, it's much worse than the size of a small, tiny crystal of silver atoms. But both have less processing and can be viewed at multiple locations, and the patient dosage is reduced with digital X-rays. So PACS is the Picture Archival and Communication System. Basically just a network group of computers, servers and stuff, and it's able to accept any image in a DICOM format, which is the Digital Imaging and Communications in Medicine. Blah, blah, blah. So pre-processing versus post-processing with digital images. Pre-processing, this is what the computer does before it shows you the image. So it's designed to produce artifact-free digital images. So some of the examples are getting rid of the grid before it pops up. So it'll also correct the anode Hill effects, and it can reduce noise and improve contrast before you have to do anything to it. Then post-processing, this is anything that happens after you see the image. So once the image pops up, it's anything that you do as a practitioner to make it look better. You can annotate it, you can change the grayscale, you can zoom in, zoom out, and do a whole lot of other stuff. So radiobiology, any of the ionizing radiation is going to have an effect on living tissue, and this is bad for the patient. The law of Bergoni and Taibon-Bui. The more mature a cell, the more resistant to radiation it is. The younger the tissue and organs, the more radiosensitive they are. Tissues with higher metabolic activity are more radiosensitive, and rapidly proliferating cells are more radiosensitive. So young cells with a high turnover, these are all more sensitive to radiation. Anything that's mature or not turning over a lot of cells isn't as radiosensitive. So some examples, nerve cells, muscle cells, down at the lower end of radiosensitivity, whereas your sperm cells and your lymphocytes, your blood-forming cells, these are all much, much more radiosensitive because they're constantly producing new cells. Moving on to fetal risk. So obviously, young cells, high metabolic activity, these are going to be very, very radiosensitive. The first 2 weeks are the most radiosensitive. So this is where you get that all or nothing response. The fetus is either aborted or continues without any problems. You get a negligible risk of less than 1 rad, and a very, very low risk of less than 10 rads if you have to x-ray the patient for whatever reason. Stochastic effect. So stochastic is random in nature. So this is where the probability of the occurrence, rather than the severity, increases with the dose increasage. So if you increase the dose, it's more likely that you'll get cancer. The cancer isn't necessarily going to be more severe. But there's no threshold below which the risk is eliminated. So if you're at 0.1 rads, there's still a small risk of getting cancer. Whereas deterministic or non-stochastic effects, at 0.1 rads, they're not going to occur, full stop. However, if you increase, once you get to that certain dose, so say at 100 rads, you will get skin erythema. I don't know the actual numbers, so don't worry about that, but at 100 rads, you'll get the skin erythema. Everyone will get skin erythema at 100 rads. As you increase the radiation after that, so you go to 200 rads, the erythema is going to be worse. So the severity increases as the dose increases. There is a threshold, so it doesn't occur below that threshold. So radiation burns, cataracts, and sterility are some examples. The earlier effects of radiation, these occur in the minutes, days, or weeks. There's the threshold dose, so we're talking about deterministic effects. You get the prodromal syndrome, then you get a latent period. So prodromal syndrome, radiation burn or something can occur. You get a latent period where you appear completely normal, and then you get a full syndrome effects, sort of a couple of days, a week later, that sort of thing. So less than 50 rads to the full body, there's no effect. 100 rads, some blood changes. 200 rads, most injured, some died. 300 rads is the LD 50 over 30 for human beings. So this is the lethal dose for 50% of the population over 30 days for human beings. And it follows a non-linear threshold dose response. Basically, it's just a non-stochastic effect, so deterministic. Holy crap, you can read all this shit if you want to. It's just related to, taking X-rays in New Zealand. Plain film X-ray characteristics. 10% density differences can be distinguished. You need to lose 10 to 15% of cortical bone before you can see it, or 40 to 50% of medullary bone before you can see it. And 10 days to 2 weeks for inflammation to cause any radiographic signs. So it's not particularly sensitive. Computed tomography, or CT, uses pencil-thin beams of X-rays, and the computer will reformat it into any plane, so axial, sagittal, or frontal. even 3D if you want. It's a much more sensitive modality than plain film. You get excellent depiction of osseous structures. It's really quick, and it's very good at demonstrating hyperacute intracranial hemorrhage. So someone that's been in a car crash is going to go for a CT, not an MRI, because it's much better at demonstrating that hemorrhage. Again, CT does use X-rays, so the limitations of CT are pretty much the same as the limitations of using plain film. So we can't use pregnancy, someone's sensitive to contrast, blah, blah, blah. Plus you get some beam hardening artifacts. You guys don't need to know that. MRI. So this doesn't use ionizing radiation, so there's no harmful effect to the patient, which is great. Again, you can image in any plane. Unlike CT, it's not reformatted. You can actually image it in that plane. It's the best soft tissue contrast of any modality, but what it does is it orients the hydrogen atoms in a magnetic plane and then listens for a signal from them with that. Indications for MRI, basically anything that's soft tissue, so neurological signs, you're looking at nerve involvement or brain involvement, joint arrangement, so anything that's going to injure like a meniscus or a tendon or a ligament. Malignancy, it's good for looking at the staging and characterization if it's invading soft tissues, if it's spread to other places. And because marrow contains a lot of fat, MRI is actually really good at looking at bone marrow. So we have a few different imaging protocols. So these basically, just remember T1 shows fat-based structures, and T2 shows water-based structures. So T2, H2O. Advantages of MRI, good soft tissue contrast. You directly acquire the image in any plane, so you don't have to reformat it as you do with the computer, and no radiation, obviously. Disadvantages, so cortical bone, osteophytes, calcifications, there's basically no signal, so they're black. It takes a long time to take the image, slowly getting better as we get higher powered magnets and better computer software and all that, but it's still taking a long time. Very expensive, so it's not readily available. Hard for claustrophobics and difficult to interpret. So you get hundreds of images for each patient and it takes hours to read. Bone scan, also known as scintigraphy. You inject the patient with a radioactive chemical, let them sit alone for a while so that the high metabolic areas can absorb it. And then you use a gamma camera to find out where the most radiation is coming from, and that tells you where there's a high amount of metabolic activity going on. Very sensitive, so 92 to 98% for changes in metabolic activity of bone. It's great, but you're never going to be able to tell me what specific tumour they have or what infection they have, or even if they have a tumour versus an infection. So again, very poor specificity. Indications, early detection of bony metastasis. So if a patient has a primary cancer and they're looking for a metastasis, what they could do is just do a bone scan and it'll show up really quickly. And obviously that's going to be more likely a metastasis than an infection because you have a history. It's good at evaluating the aggressiveness of tumours like Paget's disease. So Paget's disease can go from like a sort of benign process to an aggressive process. The more aggressive it is, the more metabolically active it is. So the higher it will show up on a bone scan. It's good for the early detection of infection. Osteomyelitis is an infection of bone. So if you remember, plain film takes 10 days to 2 weeks to see it. Bone scanning, you can detect it within an hour or so. It's really good. And it's good at detecting occult stress fractures. So contraindications, obviously you're radioactive, so pregnancy as well. Neuropathy, so anything that's going to inhibit the clearance of the radioisotope, so we want to get that radioactive material out of you. So anything that could decrease that clearance, obviously there's going to be a contraindication of a bone scan. And again, same sort of justification for taking an X-ray because you are using ionizing radiation. bone mineral density analysis, commonly called a DEXA. So, like I said, 30 to 50% bone loss to be able to tell if they're osteoporotic or have osteopenia. Dual energy X-ray absorptiometry is very, very accurate. Pass through 2 different X-rays and you measure the attenuation. Very little energy radiation exposure, but it doesn't create an image, it only creates a little plot of information on a graph. Diagnostic ultrasound, so you send ultrasonic waves into the patient. They're then reflected differently off different tissues, so bone's going to reflect it a lot better than, I don't know, muscle. So you then get an image in real time as well, which is good, and you can interpret that. So when doing an ultrasound, you have a transducer, which is a transmitter and a receiver in one, which contains piezoelectric crystals. So those piezoelectric crystals, if you put an electric signal into them, they'll vibrate and create an ultrasonic wave. If you put an ultrasonic wave into them, they'll vibrate and produce an electric charge. So this is how we, basically the basic way the ultrasonic picture is created. And that's it for today. Any questions or anything? Your test is, whenever it is, it's 40 MCQs. You guys have an hour. I don't expect many of you to take the full hour, but again, you've got that time, so you can if you want to. Fairly straightforward. Any questions about the test or anything? Thank you so much for having me as a lecturer.